I am going to talk about the treatment options for the patients after liver transplantation. And the agenda for my presentation today is this one. I'm going to describe the antiviral options in patients with mild hepatitis C recurrence, patients with compensated cirrhosis, patients with decompensated cirrhosis, fibrosis and cholestatic hepatitis, and then at the end, I'm going to comment a little bit about the DAA failures, despite there is no information in liver transplant recipients, but we are going to extrapolate some of the data in the immunocompetent patients. So you all know that the natural history of the hepatitis C recurrence after transplantation is accelerated, and 20–30% of the patients develop cirrhosis within 5 years of transplantation if the patient reached the time of liver transplantation with HCV RNA detectable. And the main problem with this patient is that these patients with cirrhosis will develop clinical decompensation within a year after the diagnosis of cirrhosis. And more important than that is that hepatitis C positive recipients have lower survival rates as compared to patients transplanted with other etiologies. So it is important, for this reason, it is important to treat the patient and to eradicate the virus. And these are the treatment options that we have so far. These two lines are not available yet, at least in Europe, because the combination of grazoprevir and elbasvir has been approved by the FDA, but we don't have it here yet. And velpatasvir and sofosbuvir is going to be approved by the FDA maybe this year. So far we have available these drugs, and in order to decide which one is the best treatment option for a patient, it is important to take into consideration the degree of liver dysfunction, because there are some drugs that cannot be used in patients with advanced liver disease, especially protease inhibitors. There are other treatments that are not recommended in patients with end-stage renal disease, glomerular filtration rate lower than 30, and these drugs are the sofosbuvir-based therapies. And it is also important to take into account that some of the antiviral drugs have potential drug-drug interactions with the calcineurin inhibitors, and because of that, some of the drugs are not recommended to associate with cyclosporine or tacrolimus, and in some cases, for example, the use of the 3D or the 2D regime, the combination is allowed, but you need to adjust the dose of the immunosuppressant. And I'm not going to comment that on detail, because this is going to be reviewed in the next presentation. And let's begin with the treatment of patients with mild hepatitis C recurrence or compensated cirrhosis. And here's the first combination that we had available, is the combination of simeprevir and sofosbuvir. And in this slide, I'm showing you some of the data evaluating this combination. The first three studies are the Reallife cohorts, and the last one is a clinical trial that is going to be presented at this Iselle meeting, and I extracted the data from the abstract. As you can see here, in all the Reallife cohorts, the SVR rate is around between 85 and 90%. And from these cohorts, you can learn that patients with advanced fibrosis, F3 or F4, have lower SVR rates as compared to patients with less advanced fibrosis. You can see here 86 versus 93, 81 versus 93, and this is especially true for patients infected with genotype 1A. As you can see here in dark green, patients with genotype 1A and advanced fibrosis have lower SVR rates as compared to the other group of patients. And in the clinical trial, which is the Galaxy, it's a randomized controlled trial that evaluates the combination of sofosbuvir and simeprevir with or without riba for 12 or 24 weeks. And as you can see here, the SVR rates in the patients that had been reported in the abstract is 93, and we hope to see the complete results of this study during the meeting. The second combination is the dacatasville and sofosbuvir that has been evaluated in the Ally 1 trial. Here, a small number of transplant patients, 53, were included and received the combination of dacatasville and sofosbuvir, always with riba, at a starting dose of 600 milligrams per day. The patients included in this trial had various degrees of fibrosis, but most of the patients had advanced fibrosis, F3 or F4. And as you can see here, the overall SVR rate in this study was 94, and most of the patients were genotype 1A, and in this patient, SVR rate was 97. It is important to note that here, the combination achieved a good SVR rate even in patients with genotype 3. The problem is that the number of patients with genotype 3 enrolled in this trial is very low, and it's difficult to extrapolate the results to more number of patients. The other combination is the combination of ombitazvir, paritaprevir, dasabuvir with ribavirin that was evaluated in the CORAL-1 trial. Here, patients with mild fibrosis, F0 to F2, received this combination for 24 weeks. As you can see here, the results are excellent. 96% of the patients achieved sustained virological response, almost with no side effects. Only 17% of the patients developed anemia. Only 3% of the patients discontinue early the therapy, and only 6% develop serious adverse events. It is important to notice that there were no cases of rejection or renal impairment, and this is important because, as you all know, there's a strong interaction between the calcineurin inhibitors and the paritaprevir ritonavir, and therefore you need to adjust the dose of tacrolimus and cyclosporin when you start these drugs, with the potential risk of rejection or toxicity related to overdose of the treatment. Despite that, there were no cases of these problems. This combination has more recently evaluated in the cohort 2 from this study, the CORAL-1, and this was presented at the last American meeting. And the difference with the previous study is that here patients with F3 fibrosis were allowed and were included in this trial. And the other difference is that patients infected with genotype 1b, naive or relapsers to a previous course of therapy did not receive riba. And this is important because this is one of the first studies evaluating the antiviral combinations without riba in liver transplant recipients. Here are the most important characteristics of these patients. 27 received riba and 13 did not receive riba. As you can see here, despite that F3 patients were allowed in this study, only 4 patients with F3 fibrosis were included. So again, it's difficult to extrapolate the data to patients with more advanced disease. The results, the efficacy results are very good. The overall SVR rate was 98%. There was only one virological failure in the group of patients receiving riba. There was a patient with genotype 1A who was naive to the therapy after transplantation. And again, the tolerance to this treatment was very good. Only 30% of the patients receiving riba developed anemia. There was one case of mild rejection during the therapy, and therefore the drug was discontinued in this patient. There was one case of severe hyperbilirubinemia and one case of serious adverse event. And then the other combination is ledipasvir and sofosbuvir that has been commented here before. These are the combined data from the SOLAR-1 and the SOLAR-2 trial. As you all know, these studies evaluated the combination of sofosbuvir, ledipasvir, always with ribavirin for 12 or 24 weeks. And here I'm presenting the data of the 3,300 patients with mild fibrosis or compensated cirrhosis. In this group of patients, ribavirin was used at weight-based manner. Again, most of the patients were genotype 1A. Most of the patients were treatment experienced, and 1/3 of these patients had cirrhosis. Here you can see the efficacy of this combination is very high, around 97%, with no differences between patients who received the therapy for 12 or 24 weeks, and no differences between patients who had mild fibrosis or patients who had compensated cirrhosis. Let's move now to the treatment of patients with decompensated cirrhosis after liver transplantation. Here are the results of the SOLAR-1 and the SOLAR-2 trial, the combined results. The difference with the population of patients with compensated cirrhosis or mild fibrosis is that here patients start ribavirin at 600 milligrams per day, and then the dose was adjusted according to hemoglobin levels. In patients with child B, the SVR rates were good, 94%, but in child C patients after transplantation, the results are not so good, 50% in the group of patients who received 12 weeks of therapy and 78% in the group of patients who received 24 weeks. The problem here is that the number of patients is really small and it's difficult to recommend that all patients with child C cirrhosis should be treated for 24 weeks. We need more data to make such a recommendation. Then I'm presenting you the data from the dacatasville compassionate use that was recently published in liver transplantation. Here, a cohort of patients with advanced liver disease after transplantation received a combination of dacatasville and sofosbuvir or dacatasville plus simeprovir. Most of the patients received dacatasville and sofosbuvir, as you can see here. 39% of the patients were genotype 1 infected. Half of the patients had decompensation after transplantation, child group B or C. The median MEL score was 13, and a third of the patients received RIBA. RIBA was more commonly used in the group of patients who received dacatasville in combination with simeprovir. Here you can see the efficacy results. 91% of the patients treated with dacatasville and sofosbuvir achieved sustained virological response, while only 72% of the patients treated with dacatasville and simeprovir achieved virological response. Almost all of the virological failures were observed in the group of patients treated with dacatasville and simeprovir. There were 3 breakthroughs and 2 relapses. And the SVR rate was low here because of the non-virological failures. A brief comment about the treatment of fibrosing cholestatic hepatitis. This is just one slide to show you how well these patients go with every treatment, a combination of sofosbuvir plus RIBA, dacatasville and sofosbuvir, and ledipasvir sofosbuvir within the SOLAR-1 and SOLAR-2 trial. As you can see here, almost all patients with fibrosing cholestatic hepatitis were cured with the combination, and this was also observed in the Reallife data. For example, in patients treated with sofosbuvir and simeprovir, again, patients with fibrosing cholestatic hepatitis did very well with this combination. So I think that we fear this a lot, but right now is the best population that we have to treat after transplantation. And just to finish my talk, I'm going to talk a little bit about the treatment of DAA failures. As I said before, there are no data in liver transplant patients, but maybe we can extrapolate some of the data from the immunocompetent patients, and then we can discuss that later. These are the Iselle recommendations. As you can see here, Iselle, the guidelines published last year, they said that all patients who failed an interferon-free regime should be received or should be retreated with that sofosbuvir-based treatment. And the other drug should be different from the one that the patient received in the first treatment. For example, if the patient received the combination of sofosbuvir and simeprovir and failed, the retreatment should include an NS5A inhibitor, for example, sofosbuvir ledipasvir or sofosbuvir dacatasville. And the treatment should be performed during 12 or 24 weeks, but always with RIBA. But if the patient received the first treatment include an NS5A inhibitor, the retreatment should include a protease inhibitor. And again, the treatment should be performed for 12 or 24 weeks in patients with advanced disease, always with RIBA. What about patients who failed 3D or 2D regimes? They recommend to retreat the patient with almost all of the combination, sofosbuvir ledipasvir, sofosbuvir simeprovir, or sofosbuvir dacatasville, as you can see here. What about the American guidelines? They say that it's better to defer the treatment if a patient failed an interferon-free therapy, because we don't have enough information to make strong recommendations to retreat patients with previous DAA failure. But if you need to treat the patient now because the patient is in urgent to be treated, you have to perform a testing for the presence of resistance-associated variants. If the patient has no resistance variants to NS5A, you can treat the patient with ledipasvir sofosbuvir plus RIBA for 24 weeks. If the patient has NS5A RABs but no NS3 RABs, you can treat the patient with simeprovir, sofosbuvir, and RIBA for 24 weeks. And if the patient have both NS5A and NS3, you can use combination of several drugs. For example, 3D plus SOF plus RIBA, or grasopreviral plus SOF plus RIBA for 12 or 24 weeks. Let's see what evidence do we have to make such recommendations. The first two studies I'm going to show you are real-life cohorts presented at the last American meeting. This study included patients who failed sofosbuvir and cimeprevir, 34 patients, most of the patients infected with genotype 1A, most of the patients with advanced fibrosis, F3 or F4, a third of the patients with decompensation, and this study included 10 liver transplant patients. And all these patients were retreated with sofosbuvir-ledipasvir. As you can see here, the overall SVR rate was really good, 96%. There was only one virological failure, one relapse in the group of patients who received ledipasvir and sofosbuvir for 12 weeks without RIBA. Another cohort, very similar, 31 patients. The characteristics are very similar, and here the SVR rate was 85%, and in the group of patients with cirrhosis was 91. There were 2 relapsers in this group of patients. Here, there were only 3 liver transplant recipients, but again, the number of patients with cirrhosis and decompensation is really high. What about the patients who failed treatment with ledipasvir and sofosbuvir? We don't have data yet, and maybe we will have some data at this Iselle meeting, but what we know is that these patients can be retreated again with ledipasvir and sofosbuvir, and the problem is that the patient who has NS5A RABs had a very low SVR rates, 60%, as compared to patients who do not have baseline RABs. So we don't have the correct answer or the best treatment for the patients who fail ledipasvir and sofosbuvir. Maybe it's better to change the treatment and use cimeprevir and sofosbuvir, but we don't know yet, and we don't have this information. What about 3D failures? This is a study, again, presented at the last American meeting, the QUARTZ study that retreated these patients with the combination of 3D plus SOF. Here, in patients with genotype 1A without cirrhosis, the treatment was administered for 12 weeks, and in the group of patients with genotype 1 and cirrhosis, the treatment was administered for 24 weeks, and in genotype 1B patients, there was, the administration was 3D plus SOF without RIBA. These are the efficacy. The study is very small, but you can see that it's possible to retreat the patient with this same regime, the 3D regime, plus sofosbuvir plus RIBA with an excellent results. And finally, this study shows that patients who receive short treatment courses of grasoprevir and elbasvir plus sofosbuvir can be retreated with the same combination using RIBA for 12 weeks, and as you can see here, the efficacy is really high. So in conclusion, I have to say that after liver transplantation, antiviral therapy achieved very good SVR rates, especially in patients with mild fibrosis stages or compensated cirrhosis. So we need to treat the patient early after transplantation to avoid the presence of cirrhosis or decompensation. The decision or the election of the antiviral regime should be based on the status of the patients, the degree of liver dysfunction, the immunosuppression that the patient was receiving, the degree of renal dysfunction if the patient has, and there are some issues that need to be addressed or need further studies: the need of RIBA, the optimal treatment duration in patients with decompensated cirrhosis after transplantation, and the treatment of DAA failures. So thank you very much for your attention.